Last time we were talking about inflammation, and we said inflammation is the response of vascularized tissue to remove the initial cause of injury. So inflammation is just there to um, it's just there to sorry about that, guys. Yeah, so inflammation just basically does three things. It's just a response of vascularized tissue to help us remove the initial cause of injury, remove the dead cells that injury would have caused, and initiate a repair if there's a need. Because inflammation typically occurs in response to a particular injurious stimulus, either from trauma, either from infection, foreign body, or necrosis. So we need to get rid of that injurious stimulus. We need to get rid of the dead tissue that it has caused and initiate a repair. That is inflammation. So it can be categorized into two forms, the acute and the chronic form. Acute and chronic. One thing about acute inflammation is that it is the initial response to all these events that we have said. Foreign body entering a cell, infection getting inside a cell, trauma of a particular tissue. The first response will be the acute inflammation. Chronic inflammation now sets in when that stimulus is now persistent, when it's prolonged, when the acute inflammatory response cannot take care of it. It can progress to chronic inflammation. Although in some situations, you can even have the inflammation starting in the chronic phase. So we'll talk more about that as we progress. So then we also said inflammation can be harmful in some situations, particularly in septic shock when the infection is already in the blood and there's an immune overdrive. So it's more like a self-perpetuation. It's just there, continue, and it doesn't get resolved until it starts causing damage, like end organ damage. Then we said in some situations too, it can, for example, if there's an acute inflammatory response to an infection, if the infection is persistent, for example, tuberculosis, it can later activate the chronic inflammatory cells to help it eradicate it, which they don't even eradicate at the end of the day. But one thing is particular to chronic inflammation, they will always cause tissue damage. And as they are causing that damage, there will be an attempt to repair. So all these things work together to cause injury to the body. So inflammation to a persistent infection like tuberculosis can be harmful because it can trigger chronic inflammation, which will further cause damage to the body. Then in some situations, inflammatory response can be inappropriate when you have an inflammatory response being directed towards self-antigens, like in case of autoimmune diseases. That is bad. So what are the cardinal symptoms of inflammation that we talked about there? So we said rubor and callor. That is rubor for redness, callor for warmth. And we said the major reason for rubor and callor is due to vasodilation. So vasodilation is when you have relaxation of the blood vessels and you have increased blood flow to that area. So when there's increased blood flow, you have more blood flow in that area. Of course, blood is red. So because it contains red blood cells, so that area is going to be red because of the blood that is there. And because we said blood carries heat from metabolism, that area is going to be warm. And we talked about the mediators that are responsible for that. We said histamine and bradykinin. Those are the first two that we always want to remember for almost all the cardinal signs of inflammation. Histamine and bradykinin, they can relax those vascular structures. Then in addition to that, prostaglandin, particularly PGI2, which is produced from COX-2. So PGI2 and nitric oxide, they can also vasodilate and increase blood flow, which can deliver more heat, causing the callor, and deliver more red blood cell that will make the area red. Then we said another thing that happens, one of the other cardinal signs includes tumor, and this is due to release of some inflammatory mediators like leukotriene, CDE, our histamine, bradykinin, and serotonin. Those one cause contraction of the endothelial cells, creating spaces within those endothelial cells for fluid to extravasate from the vessels into the tissue. And those fluid are rich in protein. So they're actually doing that to increase delivery of protein to that inflammatory site so that they can initiate uh, repair or resolution of whatever is happening there. So that is the reason why you have that swelling. And again, that extravasation of fluid to that area will also cause swelling of that area, and it will not make you want to use that particular organ or tissue that is affected, organ as a whole now. So because one of uh the complication of inflammation is what? Focal laceae. And we said that focal laceae is due to the pain, the swelling, and even the, yeah, so majorly the pain and the swelling. So if you have swelling in a particular area, you might not want to use it. If there's pain in a particular area, you might not want to touch it. So all these things will actually help to resolve the problem and prevent use of that particular structure. So we should not forget those mediators that are responsible for the tumor: the leukotrienes, the histamine, serotonin. They contract the endothelial cells, create more space so that fluid can extravasate out into the tissue. So the fluid that we are delivering contains some proteins. Proteins, and fluid enters that area, makes that area swell up, and you don't want to use that particular tissue. The proteins are also there will help with the repair of whatever is happening in that region. So then the dollar is due to the pain. We said bradykinin, prostaglandin, E2, and histamine, because they stimulate the sensory nerve endings. So if there's pain in that area, you don't want to use that organ. There's functional laceae. So functional laceae is the last component, which is loss of function. All these uh, pre-mentioned one, which is dollar tumor, are basically the one that is majorly responsible for the folicular. So there's inability to make feast due to cellulitis. So if cellulitis from maybe bacterial infection affecting the subcutaneous tissue is what is driving that inflammation, if you have all this tumor and dollar in response to that, you will not be able to use that hand, and that can help to relax that hand for the healing process to happen. So what are the systemic manifestation of acute inflammation, or inflammation generally? Fever, leukocytosis, and elevation of the acute phase reactants. So we discussed the mechanism for the fever. We said, for example, if there's an infection, all the infections will have different pyrogen. So if it's like a gram negative, they have elaboration of this LPS, which is a lipopolysaccharide. If it's gram positive, lipoteichoic acid. If it's a viruses, the nucleic acid and other things. So those patterns are known as the pathogen-associated molecular pattern, and they are recognized by the toll-like receptors on the macrophages. So once those pyrogens are released, the they are the PMP that I talked about. They are recognized by the toll-like receptors of the macrophages, and in response to that, the macrophages will release some cytokines like interleukin 1 and TNF. And these ones are the ones that mediate fever from our immunology. TNF and interleukin 1 is responsible for fever. And how will they do that? They will stimulate the activity of the cyclooxygenase in the perivascular cells of the anterior hypothalamus, so that cyclooxygenase can work and produce prostaglandin E2. And what prostaglandin E2 will do is to increase the bar of the temperature, increase the set point of the temperature. And we said it that once you increase the set point of the temperature of the set point of the temperature set point of the hypothalamus, what the body will want to do is to also work to increase its own core body temperature to that set point. So in the process, the metabolic rate of the body is going to be increased so that they can generate more heat. And also the body is going to try to contract the muscles, causing shivering, because muscular contraction generates heat too. It's a thermogenic event, so that you can increase the uh, heat generating ability of the body to meet that increased temperature set point. Then we said leukocytosis is also one of them, and leukocytosis is just basically the inflammatory response from the vasodilation. It's going to cause leukocytosis, particularly, although the component of this leukocytosis will depend on the inciting agent. So if it's a bacteria, it's going to be majorly due to increase in the neutrophil count. So if it's like a virus, it's going to be due to increase in the lymphocyte count. So that is that about leukocytes. Then elevation of the acute phase reactant. So we said the acute phase reactant are just elevated in response to interleukin 6 that is released, from the macrophages predominantly. And what they typically do is just to increase the acute phase reactant. And we said those acute phase reactants also helps to modulate the process of inflammation. Some of them have antimicrobial activity, some of them facilitate, clearance of the microbes. They have so many. Some of them initiate tissue repair and stasis and hemostasis and all those things. So looking at them one by one, we mentioned C-reactive protein. We said C-reactive protein is a complement regulator, and it's also an opsonizing agent. So they can bind to the pathogen associated molecular patterns on the microbes, or even damage associated molecular pattern on the micro on the tissue that is damaged. And what they will do at the end of the day is to stimulate the phagocyte to recognize them. So once the phagocytes have recognized them, they bind to that tissue and they degrade it. So that is opsonization. We also said C-reactive protein can activate C1q, which can activate the complement along the classic pathway. So in the process, helping to fix complement. And we said it's very, very important as a marker for inflammation. So the next one we discussed was ferritin. So we said ferritin typically binds and sequesters iron, within macrophages of the bone marrow, the bone rather, and the liver, so that it doesn't make iron available for the microbes to thrive, because we said iron is important for the metabolism of those microbes. So they want to use iron to synthesize the enzyme for DNA synthesis, DNA replication, and all those things. Then the next one we discussed was fibrinogen. So all these ones that we are saying are those ones that are upregulated. So these are the ones that are increased in inflammation. So we talked about fibrinogen to be a coagulation factor. So when there's coagulation from this fibrinogen activation, you convert the fibrinogen to fibrin so that you can achieve homeostasis and confine that microbes to that area so that it doesn't leave. Then we also said that it promotes endothelial repair because it typically forms a scaffold, for repair to happen. So if you are going to have deposition of maybe collagen or anything on a particular surface, they will actually deposit on the scaffold of fibrin, and you tend to get your fibrin from fibrinogen. And we said it correlates with ESR because it's one of the major acute phase reactant that determines the erythrocyte sedimentation rate, which we are still going to talk about. Then aptoglobin is another one. Aptoglobin basically binds to extracellular hemoglobin, so mops it out of the circulation so that it doesn't release iron to uh to generate all these reactive oxygen species via the Fenton reaction. So we said that. Then we talked about hepcidin too, that hepcidin basically helps to reduce the amount of iron too. But how does it do it? It degrades ferroportin, which is a transporter that is present in the intestinal cells that helps to reabsorb iron. So once hepcidin is there and it binds and degrades ferroportin, you don't have any ferroportin to absorb iron in the intestine. So there's little iron available for the microbes to use. Or it can bind to the macrophages and prevent release of iron from those macrophages. So when they are not released, there's nothing for the microbe to use. And at the same time, it's going to be causing iron deficiency. So, but we don't call it iron deficiency like per se, we just call it anemia of chronic disease. But the anemia is actually secondary to iron deficiency. Then we talked about procalcitonin that is elevated in bacterial infection and normally viral. Then serum amyloid A is also another acute phase reactant that is elevated in um, in inflammation, and particularly when the inflammation gets to chronic, there's high tendency of this SSA accumulating and getting misfolded to cause amyloidosis. Like it's one of those amyloid protein that we talked about when we were discussing amyloidosis, and the type of amyloidosis that it typically causes is known as secondary amyloidosis. Then we talk about the ones that are down-regulated. Almost all of them are actually down-regulated so that you can reduce the amino acid that is dedicated to their own production. So those amino acids that you are using to form them can be easily channeled to form the positive or the upregulated acute phase reactant. Then we talked about ESR. We talked about ESR to be a marker of inflammation, that we expect ESR to typically increase in most settings of inflammation. I would say the base of ESR is that red blood cells themselves, they have some negative charges on their surface because they have this salic acid glycoprotein that contains all these negative charges. So um, red blood cells, you put them in a tube, they tend to separate because of the repulsion from those negative charges. So if there's inflammation ongoing and there's increased elaboration of those acute phase reactants, particularly fibrinogen will bind to those negative charges, neutralize them, and it will make the red blood cell come together. They become denser and they can easily settle because the principle of erythrocyte sedimentation rate is the rate by which the erythrocyte can sediment in a tube to the bottom. You can sediment from up to down. So something that weighs more will sediment faster because gravity will pull it down compared to something that weighs less. And how will they weigh more? When they aggregate together, when they agglutinate, they tend to have an increased density. So what will make them aggregate? Neutralize all the negative charges. How will you neutralize the negative charges? Increase fibrinogen so that fibrinogen can mop up all those negative charges The red blood cell can come together, they can aggregate, and they can fall at a higher rate. That is ESR. ESR is measured in millimeter per hour. So the distance in which they are covering from up to down is in millimeter. The rate or the time that they are dropping, brings about the hour that we are looking at. So the shorter the time, the higher the ESR. That's it, because ESR is millimeter per hour. So the shorter the time, the faster or the higher the ESR. So what are those things that elevate ESR? We said most anemias, most anemias. So we said in anemia, relative to the fibrinogen, you have less red blood cell compared to the fibrinogen. So you have more fibrinogen to neutralize all the charges and make the red blood cells agglutinate together and fall at a higher rate, causing elevation of the ESR. We said infections elaborate fibrinogen because they can cause inflammation, and you have increased ESR. Inflammation generally, but we are looking at some specific disease. Polymyalgia rheumatica and giant cell arthritis. We said they even go hand in hand. Polymyalgia rheumatica is associated with giant cell arthritis. So that's another way to remind ourselves of those conditions. And both of them we have elevated ESR. Cancers trigger inflammation, so they have elevated ESR. So we said renal disease too can cause ESR because somebody that has a CKD can have edema, so there is this dilutional anemia that can cause elevated ESR. We said anemia generally can cause ESR. So once you can leak anything you are dealing with to anemia, ESR will be increased. Nephrotic syndrome too, we said in someone that has nephrotic syndrome, they can have the edema, which can cause the dilutional anemia, or nephrotic syndrome, they are losing antithrombin 3, which is an anticoagulant. So if you are losing an anticoagulant, that means that you have increased tendency of coagulation. So there's increased tendency of recruitment of fibrinogen. Fibrinogen doesn't escape in nephrotic syndrome because it is a larger molecule compared to all these antithrombin and the other ones. So it stays, and it can fix itself to the red blood cell, neutralize those charges, make them aggregate and descend. Then pregnancy is the last one that can increase ESR. We said pregnancy is a situation or a condition that there is increased plasma volume. So people that are pregnant have increased plasma volume. That's why you see edema and everywhere when somebody is pregnant. So that one can even cause dilutional anemia that can explain the increased ESR. So we said it's only in some few anemic setting that ESR is reduced. So particularly someone that has microcytosis. So someone that has microcytosis or someone with sickle cell anemia, the uh, there is reduced surface area of the red blood cell to agglutinate with the fibrinogen. So that is why they don't eventually aggregate and sediment at a higher rate. So because of the reduced surface area to bind to fibrinogen, and of course hypofibrinogenemia is self-explanatory. There's no fibrinogen to bind to the red blood cell to neutralize the charges and make them aggregate. So they don't aggregate, they are not dense, and they don't fall at a faster rate. Then polycythemia, there's increased red blood cell count relative to the fibrinogen. So they kind of dilute the fibrinogen. So there's no enough fibrinogen to neutralize all those charges. So they are kind of separated and they fall at a lesser rate. Heart failure is the only one that the mechanism is not known. But if anybody is able to find anything to explain heart failure, please, the person should reach out to me. Yeah, so acute inflammation, we said is a specific type of inflammation that actually happens in the early phase in response to maybe an infection, foreign body, or trauma. So what I just want us to always remember about acute inflammation is that the cells that are predominantly involved in acute inflammation are the neutrophils. So that's one of the ways the question can come around. The
Dr.
neutrophils.
Babawale,
Yeah, Dr.
please, I have
Precious.
a quick. It's not Precious, Dr. Antonia. I
Oh,
have.
Dr. Antonia.
Yeah, I have a quick question, please. I know I wasn't around in the class,
Okay.
but you said something about something about CRP, C-reactive protein,
Okay.
having something to do with C12.
C1Q. C1Q.
Yeah,
Mm-hmm.
C1Q.
Yes.
Okay, so I missed that. So that's
Okay.
my question. What it has to do with
Yeah.
C1Q?
It can activate C1Q.
Oh,
C1Q
okay.
is one of the components of the classical pathway. We have C1Q,
Yes.
C1R, C1S. So if it
Mm-hmm.
activates that C1Q, it can activate C2 and C4. So
Okay.
C2 and C4 can combine together. You remember those things to form C3.
Mm-hmm.
You get, so from there you have the complement activated. So that's why they are saying C-reactive protein can be an activator of the complement pathway. So it's
Oh,
through
okay.
that mechanism. Yes.
Okay. Thank you.
Yeah, you're welcome. So okay, so that's that about ACK information. We have to always remember that the neutrophils are those things that are predominantly there. So what just happens is once let's take an infection to be the inciting stimulus. So an infection, you know, comes around maybe from skin or something, and there's a skin infection. The infection is going to contain the pathogen associated molecular pattern, which is going to be recognized by cells of the innate immunity, particularly the dendritic cells, the macrophages, and all those things. So they have toll-like receptors on them that can recognize all those PMPs. So when they recognize them, they release some cytokines like interleukin 1, TNF, and all those things. And they themselves will now activate some resident cells in that side of the injury, particularly the mast cells. Mast cells are very important to be said. We must mention them because once the interleukins or the macrophages and the dendritic cells activate the mast cells, they are going to degranulate. So once they degranulate, they are going to release histamine. And histamine is the major one that is responsible for vasodilation. So the other macrophages too, the dendritic can elaborate other things like the bradykinin, the prostaglandin, the nitric oxide that will help with the vasodilation so that you can recruit more cells to that area. So that's why the first thing you have in inflammation is vasodilation. We can see we can see the component of acute inflammation, the vascular one, vascular vasodilation, causing increased blood flow. And we also said there's a change in the vascular permeability. So part of the cytokines that is released by those macrophages will activate those endothelial cells. And again, we are going to have elaboration of some some uh some cytokines like leukotrienes, like serotonin, like histamine, that's going to cause contraction of those endothelial cells. So once they get contracted, we are going to have that fluid that has, rushed down to that area following the vasodilation. They will now extravasate into the tissue. Now, that extravasation into the tissue increases the viscosity of the fluid that is left within the vascular compartment, causing stasis. Now, what will the stasis do? The stasis will change the orientation of the movement of the cells in the vascular space. So the red blood cell will be forced to aggregate in the center, while the white blood cells will be forced to marginalize. They will be forced to move towards the margin of the endothelial cells so that they can attach to the already activated endothelial cells, so that they can now find their way into the tissue and extravasate. So we are going to talk about that extravasation very well later. So that
Dr. Babale,
yes, Dr. Olushola.
just a quick one. You talked about the heart cells, how they cause whatever.
Which one?
In the sense of when you said heart failure, how they
Okay.
cause decrease ESR.
Heart failure.
Yes.
Okay. Yeah, I said the mechanism is
So
not.
in the context of what you are explaining just now, like stasis and all of that, can't it
Okay.
be the reason?
Hmm? Stasis. No.
Like when you have heart failure, it's not moving. The rate the rate at which the blood is moving is lower, right?
Okay, so
I
let me
think it's
explain.
lower.
Let me explain what you are saying. So one thing about ECR is that you are not doing ECR in the body. You are removing blood. Do you understand? You are removing blood from the body and you are putting it in a tube and you are sedimenting it. So the heart is not controlling that blood again. So it will not be. I don't know if you got what I'm saying, Dr. Rishola. So you have removed the blood from the body. You are
Mm-hmm.
putting it in a tube and you are sedimenting it. So the heart that have failed has no control over that blood again. So that might not
Okay,
that might
okay,
not
okay.
work. You get what I'm saying here. So that might not work to explain it. That might not work. So uh yeah, so the vascular response first, there's vasodilation from elaboration of histamine from the mast cell, bradykinin, nitric oxide from the macrophages and the dendritic cells, so that you can have more blood flow to that area to deliver more blood cells. Then those macrophages that get to that area too, they will release some cytokines. Some of them will, like TNF1 and interleukin, that will activate the nearby endothelial cells. They will also release leukotriene, serotonin that will contract the endothelial cells. When they contract that endothelial cells, plasma protein is going to escape into the tissues from those endothelial cells. That will reduce the viscosity of the blood. That will increase the viscosity of the blood because plasma is containing fluid. So the blood will remain more viscous and to be more concentrated in the cells because the cells will stay behind. So what will now happen to the cells? Red blood cell will stay in the center, while the white blood cells will go to the margin of the endothelial cells so that they can attach to the activated endothelial cells. So then the next thing is for the attached endothelial white blood cell to the endothelial cell to now move across those endothelial cells into the tissue. So that's the process of extravasation of the leukocytes. So they're able to travel to the focus of injury. So we talked about the mediators for the acute inflammation. There are so many of them. I don't think we really need to bother ourselves because all these cells depend on what is inciting the problem, what is the major stimulus. So if somebody inhales maybe pollen now or dust mite, you are going to have type 1 hypersensitivity. It's an inflammatory response. So that's when your basophils will be predominant, your eosinophils rather. So eosinophils will be predominant in all those ones too. Then, if it's due to bacteria, of course, you are going to have your neutrophils coming around. Your complement toll-like receptor will be activated from macrophages. And if it's a case of trauma, you have to secure homeostasis first to arrest, that if there's a bleed, you want to arrest the bleeding. So you might want to use your H-man factor. So that one is not really very significant. They will not likely test those specific ones. So, but there's something called inflammasome that we said if there is inoculation of a microbe or there's trauma to an epithelial cell, the inflammasome is always present in the epithelial cell and it's like a cytoplasmic protein complex that recognizes product of dead cells. Those are the DAMPs, damage associated molecular pattern, as well as microbial product, the pathogen associated microbial pattern. The damage associated microbial pattern can also be formed from crystals. So because crystals can deposit in tissue, they can cause tissue irritation and damage, and they always release DAMPs too that will be recognized by the inflammasome. So the inflammasome will now make complex with all those dead cell microbial products and activate interleukin 1 so that they can perpetuate the inflammatory response from there. So
Sorry, Dr. Babawala, I missed out on this inflammasome. I got lost somewhere.
okay. So
So
the
did you
first
say
part,
they are located? Okay. Did you say they are located in the cytoplasm?
yes, they are located in the cytoplasm of epithelial cells. They are
Okay.
located in the cytoplasm of it. So they are cytoplasmic protein complex.
Okay.
So they are always waiting around to look for all those DAMPs and PAMPs. So
Okay.
once they see that DAMP and PAMP, they will fuse with them and they will activate release of interleukin 1. So the
Okay.
interleukin 1 can now drive, because this interleukin 1 in a way can drive inflammation. If you remember in immunology, we said interleukin 1 can cause fever. Interleukin 1 on its own can activate chemokines that can recruit other white blood cells. We said interleukin 1 can cause damage to the vascular endothelium and increase its vascular permeability. Dr. Antonio, I don't know if you remember. If you go back to immunology, it's there.
Mm-hmm.
So,
So when they bind to these DAMPs and PAMPs, they trigger cytokine release.
yes, particularly interleukin 1.
Okay.
So, which will now, start the inflammatory cascade. So it's different from the pathway of toll-like receptor.
Mm-hmm.
That one is your microbe entering. Your any cell that contains toll-like receptor recognize it first, like
Mm-hmm.
macrophages or
Mm-hmm.
dendritic cells. They recognize it first and they start releasing interleukin 2. So if that one is not happening, your inflammasome can also be a channel to drive your
Okay.
inflammatory response. So that's that. Both of them work hand in hand. So then we talk about the outcomes for acute inflammation that you can have
Sorry, Dr. Babawale, please, what's the full meaning of DAM?
damage associated molecular pattern. So damp.
Okay,
Yes,
thank you.
you're welcome. So the outcomes. So your macrophages can come in, or your neutrophils particularly, because this is acute inflammation. Neutrophils will be recruited at the end of the day. They will extravasate into that tissue and they can remove the whatever stimulus is driving the inflammation. And at the end of the day, once your neutrophils are able to remove that by phagocytosis, the next thing that the body will do is to, start releasing anti-inflammatory cytokines like interleukin 10 and TGF beta so that they can achieve resolution and healing of that inflammatory response. That is all. But in some situation, you don't have resolution of inflammation. It continues, like in sepsis. They continue to elaborate all those interleukins, driving the inflammatory drive. That is when you say it is persistent. Sometimes they can form abscess. If acute inflammation can cause abscess, it can lead to formation of abscess. So we said this abscess thing is like uh, it's more like a conglomeration of so many things. So many things can decide if abscess is going to form. So we said number one, the nature of that inciting stimulus. For example, there are some microbes that they have predilection for causing abscess, like Staph aureus. And we also said the site where the inflammation is also happening can also influence if abscess is going to be formed, particularly like the lungs, because the lung tends to, when inflammatory response is happening in the lung, they have the tendency to, the LD cells that are surrounding the inflammatory site have tendency to wall off themselves so that the inflammatory response doesn't get to them. So they start releasing fibroblasts. They start releasing start proliferating their capillaries so that they can form a cavity, a wall around themselves so that the inflammatory stuff doesn't get to them. So, and if that lung is now infected like something like Staph aureus or anaerobes that can drive lung abscess, you have abscess with that inflammation. So sometimes if the stimulus that is inciting that inflammation is persistent, is prolonged, is not something that the acute inflammatory cells can destroy, and you know that neutrophils is the major cells in the acute inflammation, they will die within 3 to 5 days. So something else needs to replace it. That's when the macrophages will now start coming in. The macrophage will now start presenting that persistent stimulus to other cells that are capable, like the T cells. So they will activate the T cells and they will start the chronic inflammatory drive. And one of the complications of chronic inflammation is scarring. We are going to talk about it. So, yeah, so let's now talk about leukocyte extravasation. So I just want us to really pay attention here because you can get one of these in your exam and it should be bonus. Once you just understand what is happening, you'll be able to figure out what they are saying. So the first one, so extravasation is just a term that is talking about how the neutrophils particularly are able to leave the vessels and get into the tissues. That is leukocyte extravasation. And I want us to know that extravasation particularly occurs at the postcapillary venous. So we said we have arteries. Arteries will form arterioles, and arterioles are the area where vasodilation typically occurs. Then after the arterioles, we have the capillaries. After the capillaries, we have the venous. After the venous, we now have the veins. So it is at the post-capillary venous, that is the venous after the capillary, immediately, that you have extravasation. That is where you have the neutrophils entering the tissue. So what is the process that the neutrophils employ to enter the tissue? So we'll take them one by one. The first one is margination and rolling. Margination and rolling. So what helps with this margination and rolling is when we have had movement of plasma from the vessels into the tissue. We said that movement of plasma will make the blood to be viscous so that you can slow down, you have stasis, and you can slow down the movement of the neutrophils. The neutrophils will now margin, they will move towards the margin of the blood vessels, attaching themselves to the endothelial cells. Now they will now start rolling. How will they roll? It is due to attachment of some ligand in the white blood cell or the neutrophils and some receptors on the endothelial cells. Now let us take the ligand and the receptor one by one. We separate them. So I just want you guys to know that there are two receptors, the integrin and the selectin. There are two receptors, the integrin and the selectin. The integrin and the selectin. Integrins are only located on the leukocyte, the neutrophils. Those are the ones that contains the integrins, the neutrophils. The selectin can be present anywhere. It just depends on the type of the selectin. We have three types: E-selectin, P-selectin, L-selectin. So from the name, we can know what they stand for. E-selectin is talking about selectin receptors that are present on the E, which is the endothelial cells. P-selectin is talking about selectin receptors that is present in the platelets, and fortunately is also present in the endothelial cells. So P-selectin is present in both regions, on the platelets and the endothelial cells. They are released from the Weber pallidate bodies. These Weber pallidate bodies are granules within the endothelial cells that can release two things: P-selectin, which is a receptor on the endothelial cells, and they can release von Willebrand factor. So when we are doing immunology, we'll talk about these Weber pallidate bodies again in immunology. So I know that the old guys can remember these Weber pallidate bodies. We can remember some of those things that release. Von Willebrand factor is one of them. P-selectin is another one, and that P-selectin is not the one for platelet. Just delete that one for platelet. I'm just mentioning it so that you guys can understand the way they got the name. So, but it's present on both the platelet and the endothelial cell. So the one that is located on the endothelial cells is actually released from the Weber pallidate bodies of the endothelial cells. So what is the last selectin? The L-selectin. So this L-selectin is not located on the endothelial cells like E and P-selectin. L-selectin is located on the leukocyte. Now, if we are saying there's a selectin and we are calling it a receptor, that means that it must have a ligand. So we said the E-selectin and the P-selectin are located on the endothelial cells. So what is their ligand? The ligand is called Sally-Lewis X. Sally-Lewis X. So Sally-Lewis X is the ligand for the two selectin receptors that are present on the endothelial cell. Sally-Lewis X interact with the E and P-selectin. Why the L-selectin on the leukocyte has its own ligand too? What is its own ligand? Glycam-1. Now, we are going to be mentioning a lot of glycam. All the glycams are ligands. They are typically present in the vascular endothelium. It is only, let's just stick with that. All the glycam are typically present on the vascular endothelium. So, if L-selectin is a receptor on the leukocyte, its own ligand is glycam. So it has I think glycosylation cell adhesion molecule 1. So we don't need to know the full meaning, but that's glycam for L-selectin. So we can go back. E-selectin and P-selectin are located on the endothelial cell, and their ligand are the Sally-Lewis X. L-selectin is located on the white blood cell. Its ligand is glycam. Now, these three guys are responsible for attachment of the leukocyte to the endothelial cells of the vasculature. And what they would do is to allow for the rolling. So the leukocyte will just be rolling on the endothelial cell. It will just be rolling. And this has a clinical significance. If there is deficiency of Sally-Lewis X, you cannot have interaction with leukocyte with the E-selectin on the vessel. You cannot have interaction of Sally-Lewis X with the P-selectin on the vessel. So there's no rolling. So there's no way neutrophils can enter into the tissue because it has to roll first. If they cannot roll, that means neutrophil cannot get to the tissue. So that is one of the cause of leukocyte adhesion deficiency problem. But in this one, this is type 2. We remember when we were doing immunology, we talked about leukocyte adhesion deficiency type 1. Here, I don't know if you guys remember
CD18,
Yes, the CD18.
fantastic.
CD18, LFA1.
LFA1.
Guys, God bless you guys. So this one is not CD18 now. This one is a type 2 form because CD18 is type 1. This is a type 2. But all of them, there are actually 3 types. All of them will have similar presentation like that type 1. It's the same thing. Neutrophilia, delayed separation of the umbilical cord, poor wound healing, no pus. Because what the component of pus in the tissue is dead neutrophils. If neutrophils cannot enter, there's no way pus will form. If neutrophil cannot enter to the tissue that is damaged, there's no way wound healing can be achieved. If neutrophil cannot leave the vessel to enter the tissue, it will pull in the blood and there will be relative neutrophilia. Those are the constellation of findings that you see in someone that has the leukocyte adhesion deficiency. So we have 3 types. All of them are causing the same thing. It's just the mechanism by which they are causing it that is different. So E-selectin and Sally-Lewis, P-selectin and Sally-Lewis L-selectin and its glycan will cause problem will help us achieve rolling and margination. So they can ask you in your exam. So there's problem with they will just mention one of these guys. They can say there's deficiency of ICAM. So at what process of leukocyte extravasation is defective? You just go and pick what you want to pick. Maybe tight binding, addition. You are smiling. That is it. So for margination and rolling, we are talking about all those things we have said. E-selectin with Sally Lewis, P-selectin, Sally Lewis, glycan, and L-selectin. If there's deficiency of Sally Lewis, the person will have leukocyte addition deficiency type 2. Now, what is the next stage after rolling? You need to bind tightly to the endothelium. What does it use to bind tightly?
Sorry, Dr. Babawale, which one is type 2?
So,
okay, the Sally Lewis. Okay, it's type 2.
The Sally Lewis is type 2. Yes. Mm-hmm. So, the next one is tight binding. We need to bind tightly. We need the leukocyte to bind tightly to the endothelial cell. How will they bind tightly? They will use, the HICAM, the VCAM, and the integrins. So we already said it that integrins is located on the leukocyte. Integrin are located on the leukocyte. So that means that ligand will definitely be in the vasculature. And we have said it already that the CAMs majorly are located in the vasculature. So if you guys can always remember that, it will be very easy to picture this step. To be honest, I know that this stuff can be very difficult to remember, but if you can follow it that way, it will be much more easier. So the integrins, leukocytes, the ICAMs, the CAMs, the vasculature. So what CAMs are we looking at now? ICAM and VCAM. So VCAM is very easy to remember. Just remember that if you are talking about VCAM, and that is on the endothelial cell, the receptor that VCAM will bind to will also start from V, which is VLA4. So we call it very late antigen. That's what it stands for. Very late antigen 4 is an integrin. So it's binding to vascular cell adhesion molecule on the vasculature. So VCAM, VLA4, very easy. Those are the ones that bind together. Now the next one is ICAM. That's the one that is actually relevant. That's the one that is clinically significant. So ICAM, will interact with the CD11-18 integrin. Now, this CD11-18 integrin codes for two types of integrin, the LFA1 and the MAC1. The LFA1 and now this LFA1 is just meaning CD11A18. MAC is CD11B18. Both of them are containing CD11. It's just if that 11 is A or B, that's what separates them. So LFA, MAC, both of them codes for the CD11-18 integrin, and they interact with the ICAM. While VCAM is for VLA4. LFA, MAC is ICAM. VLA4 is VICAM. The clinical significance here is that you guys already know when there's deficiency of CD18, the person has deficiency of that. You remember that the CD18 is common to both LFA and MAC. So that means that there's no LFA and there's no MAC. There's no way they can interact with the ICAM, and there's no way they can tightly adhere to the endothelium. So that means that the phase of extravasation that is problematic here is the tight binding, the addition, not margination or rolling, but addition. Then the next one is very simple. PCAM is both of them. So PCAM is both in the endothelium and the leukocyte. So PCAM, the same thing, PCAM. That one is now going to cause diapedesis or transmigration. What we are saying here is that it has adhered, but it now migrates across the endothelial cell. So this is it. So it now moves across it. So when something moves across it, that is trans movement. It moves across the endothelium to get into the tissues, in the interstitium of the tissues. That is transmigration, and that is achieved by the activity of PCAM 1 and 1, PCAM 1 and 1. That's it. Then when it now gets to that tissue, it has to move within that tissue. That is what we now call migration. That is not transmigration again. That is migration. That is migration. But the stimulus that is driving the migration are the chemotactic factors. So those damaged tissues, those microbial agents can elaborate some chemotactic factors factors that particularly activate or attract, rather, attract is the word, that attract neutrophils. People that have done immunology, they will remember, hematology, they will remember this chemotactic. That is why this first aid stuff, they are leading, into one another. So by the time you know it now, if you are reading it again in hematology, it's very easy to remember. So what are those chemotactic factors for neutrophils? C5a, we've said it in our immunology. C5a, we mentioned interleukin 8 too, is a neutrophilic attracting factor. Interleukin 8. Then I feel if you remember these two is enough. Interleukin 8, C5a. But if you want to know more, leukotriene B4 is another one. 5-HT is another one. Kallikrein, beta-regulatory factor, and then for me, methionine. We should just know maybe 2 or 3. They are home and dry, but particularly remember C5a and interleukin 8. Actually, if you can study it and remember them, it's good. So that
I think we have a mnemonic for it. It's chill.
Chill. Okay.
Dr. Festus gave us chill.
Oh yeah, let's hear it. So C.
Yeah. C5A.
Okay.
Then 5-HETE. Then IL-8 and then LTB4. That's a chill.
Okay. Oh, okay. That was a little bit fast for me. But
So C5A, the C in the chill.
okay.
Then the H is from the 5-HETE.
Okay.
Right?
Okay.
Then the I is the interleukin 8.
8.
Yes. And then the L is the LTB4.
Nice one.
Yeah.
So at least we've covered almost everything. That's very good. Thank you, Dr. Francois. So we should not forget, this we can always look at it maybe once more so that we can consolidate it. So the leukocytes, we have the selectins, which are the receptors, the E, the P, and the L. So the E and P is located on the endothelium. The L is on the leukocytes. The ligand because we said selectins are receptor. So the ligand for the E and P located on the endothelium are located on the leukocyte. And what is that ligand? The Sally-Lewis. We're almost done with rolling imagination. Then the last one is the L selectin on the leukocyte. What's its own ligand? The glycan. That is all. Then we'll go to tight binding. We remember the ICAM and the VCAM. The ICAM and the VCAM. What's the receptor for VCAM? It has to be an integrin. That's VLA4. Settled. Then the next one is the ICAM. What is the receptor for the ICAM? Our MAC1 and LFA1. And that's also known as CD11, CD18. So someone that has deficiency of CD18 can have leukocyte addition deficiency type 1. Then the next one is transmigration. After it has adhered, transmigrate across that endothelium that is adhering to pecam. That's also known as the epidesis. Then lastly, when it has adhered, and it has passed across that endothelium into the tissue, it wants to migrate through that tissue to get to that offending agent, migration. And that is driven by the chemotactic factor that is released from that injurious site, which includes C5a, interleukin 8, our chill. So chill, C5a, ECT, interleukin 8, and the LTB4. So that is that about the traveling or extravasation. So let us talk about chronic inflammation now. So the simple way to understand chronic inflammation is to picture chronic inflammation as anything that causes persistent stimulus. So once the stimulus becomes persistent, making the inflammatory response prolonged is going to cause chronic inflammation. So if the stimulus is persistent, the inflammatory drive is prolonged, the neutrophils that is driving acute inflammation have to die because they are short-lived. 3 to 5 days, they are gone. We need more long-lasting cells like macrophages and our T lymphocytes. So the particular cells that are predominant in chronic inflammation are the mononuclear cells. They have only one nucleus. These include the macrophages, the lymphocytes, and the plasma cells. In situations where we need to release antibodies, plasma cells will be there. our lymphocyte to be there, particularly T and B lymphocyte. Then the macrophages. Once you see those three cells, you know that that is likely to be a chronic inflammatory response. So you want to ask yourself, now before we move, another thing about chronic inflammation is it will always lead to tissue destruction, and as you are destroying that tissue, you are attempting repair through angiogenesis and fibrosis. We are going to talk more about that. So chronic inflammation is a persistent form of or prolonged form of inflammation. So it's a prolonged form of inflammation in response to a persistent stimulus in most situations that attract the mononuclear cells, which includes the macrophages, the lymphocytes, and the plasma cell, not neutrophils. And at the end of the day, they are going to cause tissue damage and tissue repair. In some situations, it can be preceded by acute inflammation. When the acute inflammatory response to that injurious stimulus cannot be taken care of, when that injurious stimulus cannot be mopped off, cannot be degraded, chronic inflammation will ensue. In some situations, it can start de novo without going through acute inflammation. For example, someone that has an autoimmune disease. Autoimmune disease doesn't start by chronic inflammation. What you are producing is antibodies against that antigen, and that will include the activity of your T cells and your B cells. That's a chronic inflammatory response. Yeah. So it's not in all situations that you have chronic inflammation occurring from or as a progression of acute inflammation. No. So what are these stimuli? We have talked about it. Sometimes it can come from persistent infection. So infection that is difficult to eradicate. What are these infections? Tuberculosis, syphilis, fungi, viruses. Not all viruses are persistent. For example, hepatitis A doesn't cause chronic inflammation. It's not persistent. Once your body mounts immune response to it, they take care of it. It's not persistent. But there are two viruses for the hepatitis family that can cause chronic inflammation, like hepatitis B and hepatitis C. There are different reasons why these guys can cause that. They have their different reasons. For example, hepatitis B has a reverse transcription activity. As the cell is killing off hepatitis B, its reverse transcription activity is producing more of the genome to produce more copies. So it persists for a long time. Hepatitis C, it is even difficult to eradicate that one because it's always changing its surface antigen. You cannot produce a specific antibody to respond to it. It will keep changing it by the process of antigenic variation. So it's difficult to eradicate. And if it's difficult to eradicate, the infection will be persistent, and you have to employ the activity of your chronic inflammatory cells, like the macrophages, the lymphocytes, and the plasma cells to eradicate it. Tuberculosis has a way of resisting inflammatory damage because of all this mycolic acid and all those things. So you want to form granuloma, and in this situation, there's going to be a persistent inflammatory response, which will become chronic. So that is that. So they're actually saying, okay, persistent infection can cause type 4 hypersensitivity. Yes, because if you look at all this infection that is listed here, the major cells that are responsible to viruses are the CD8 cells. The major cells that respond to fungi are the T lymphocytes. Particularly when it is chronic, when it is persistent, you have to employ the T lymphocyte. Then tuberculosis and syphilis, because you have to form granulomas, you have to employ the activity of your T lymphocyte, and that will be a type 4 hypersensitivity. Because you remember that we don't produce antibody against TB. Have you guys heard of antibody against me? I've not heard of it too. So these cells are not typically involved in the inflammatory response to tuberculosis. It is actually the T cells and the macrophages that respond to it, forming granuloma. Same as syphilis. They can form granuloma in syphilis too, particularly the tertiary form of syphilis. So if the infection is not persistent, can it be due to autoimmune disease? Because in autoimmune disease, the inciting stimulus is persistent too, because it is in the body. If the body is still existing, that means that the antigen is always present and the stimulus will be persistent. So, and again, what even responds to autoimmune disease are the T cells. So automatically it's the chronic inflammatory response. So if it's not persistent infection, can it be persistent foreign agents like silica, like talc, like beryllium? You can name it. If the neutrophils come around first to respond to it, they cannot degrade it. they will be forced to recruit the macrophages. And in that situation, we are going to have a chronic inflammatory response. So don't forget, persistent infection, persistent foreign agent, autoimmune disease, chronic inflammation. So what are the mediators? The most dominant cell, or the dominant cell, but rather, for chronic inflammation are the macrophages. Those are the things that will drive that inflammatory response. Now, we have said it that in chronic inflammation, as we are destroying that tissue, we are also attempting repair. So the body doesn't know that it's actually destroying the tissue. It won't know. It's trying to eradicate that material, but in the process, it's going to destroy the nearby healthy tissue. And as it's destroying them, as the macrophages are destroying them, they want to repair again. So how does it happen? The macrophage will take a sample of that microbe, let's say tuberculosis. It will go to the lymph node and present it to the T cells. Now, one thing that macrophage will do, firstly, is to release interleukin 12. Interleukin 12 will now differentiate the naive T cell to go to the interleukin 1 pathway. So the interleukin 1 will be formed. Interleukin 1 will release two things, interleukin 2 and TNF alpha. It is this I said TNF alpha, gamma interferon, interleukin 2 and gamma interferon. Please, I made a mistake. Interleukin 2 and gamma interferon. This gamma interferon will activate the macrophages via the classical pathway. If there is gamma interferon stimulation of the macrophages, they are activated through the classical pathway. And what the classical pathway is majorly all about is pro-inflammatory, release of inflammatory cytokines to destroy whatever is causing the problem. And in that situation, they're also going to be destroying the tissue. So the macrophages are going to generate reactive oxygen species via the oxidative burst to destroy the tissue. They are going to release lysosomal enzyme to destroy that agent as well as the tissue. And they are going to release other cytokines to drive the inflammation. That is all about the classic pathway. Because of the fact that the macrophages are activated through this pathway from the gamma interferon, they are going to release all these three things that I've listed: reactive oxygen species, lysosomal enzyme, and cytokine, to drive the inflammation, to eliminate that offending agent, and at the same time destroy the tissue unknowingly, iatrogenically. Then we remember that as the TFR1 are secreting gamma interferon, they are also secreting some interleukin 2. Interleukin 2 can activate the TFR2. So once TFR2 activated, TFR2 will release interleukin 4, interleukin 13. So these interleukin 4 and 13 are important to activate the macrophages through the alternative pathway. Now, the alternative pathway of activation is not actually pro-inflammatory. They don't release inflammatory mediators to drive inflammation. What they are after is repair. So they will stimulate these macrophages to be releasing growth factors, fibrous growth factors, platelet-derived growth factors, transforming growth factors. You guys remember that transforming growth factor is anti-inflammatory. And again, it can stimulate angiogenesis. It can stimulate repair, or fibrosis rather. It can stimulate fibrosis. So it's going to cause anti-inflammatory drive. So all those inflammatory cytokines will be suppressed from the TGF. The TGF is going to stimulate the recruitment and the activation of the fibroblasts that will start laying down ground substances and collagen, which will eventually lead to fibrosis. So that is why one of the complications of chronic inflammation is fibrosis and scarring. You know, fibrosis and scarring, it is due to this pathway. So once you have chronic inflammation happening and your macrophages are doing their work, they're activating T cell. T cell is now further stimulating them by releasing gamma interferon. Once the gamma interferon come in contact with the macrophage, it will make them activated in the pro-inflammatory manner, the classic pathway, and they'll start elaborating inflammatory mediators that will try to destroy the offending agent as well as the neighboring tissue. Now, in an attempt to repair, that's when the TFR2 will now come in. They will elaborate interleukin 4 and 13, not gamma interferon. Interleukin 4 and 13 that will activate the macrophage again, but in the alternate pathway, just like complement, in the alternate pathway. And this one will start releasing some growth factors. I think I have it here. Okay, yes. So growth factors like fibroblast growth factor that will cause fibrosis, transforming beta growth factor that will cause angiogenesis as well as fibrosis. And the transforming beta growth factor also has anti-inflammatory effect, which will suppress the inflammation so that you want to limit the tissue destruction and attempt to repair it. But the attempt to repair is not usually effective because it will end up forming scar. Yes, to end up forming scar. So that is why the outcomes for chronic inflammation include scarring, include amyloidosis. We can explain this already. Anybody wants to explain why we have amyloidosis? Quickly, anybody? Just one statement, we move.
Overproduction of serum amyloid A as the
Thank you.
acute phase reactant.
Thank you, Dr. Precious. Overproduction of serum amyloid A as an acute phase reactant, which will further misfold and lead to amyloid deposit. Then lastly, chronic inflammation can progress to a neoplasia. This one has so many pathways, so many mechanisms, but we are going to explain it with these two that we have. So the first thing they said, chronic hepatitis C infection causing chronic inflammation and leading to cancer. Now, we have said it that hepatitis C is one of those viruses that can cause chronic inflammation. Why? Because it persists. Why does it persist? Antigenic variation. So the macrophages, the lymphocytes are going to respond to the chronic hepatitis C, which will lead to chronic inflammation of the stomach. I said stomach, the liver. So they are going to have chronic hepatitis. Now, there will be activation of these macrophages in this pathway. You know, the pro-inflammatory one will be causing the hepatitis, the destruction, while the anti-inflammatory pathway will now try to repair, you know, all the damage that the chronic inflammatory one is causing. And in the process, it will lead to formation of what? Scar in the liver, which will lead to cirrhosis. That is why it doesn't actually jump from chronic inflammation to hepatocellular carcinoma. There will be a cirrhotic event that will lead to. So that cirrhotic event, you notice that cirrhosis is actually formation of regenerative nodules and scar. Those are the two things that you see on histology. Regenerative nodules and scar. So as the chronic inflammation is happening due to classical activation of the macrophages releasing all those pro-inflammatory cytokines, the TFR2 are also activating the macrophage in the alternative pathway to repair the damage that the chronic hepatitis is causing from the classically activated macrophage. So how do they repair that damage? They want to regenerate themselves. So the hepatocytes, because hepatocytes are actually stable cells, they are not permanent cells. They are capable of regeneration when there's a need. That is why you can harvest a part of the liver and give it to somebody. The other part of the liver can regenerate because they are stable cells. So they try to regenerate, and the alternate one will start depositing collagen, causing scarring. So due to the regeneration, there's formation of the regenerative nodules. Due to the activation of the fibroblast, there is the scar, you know, and fibrous tissue, making that liver cirrhotic. Now, the constant regeneration and scar, you know, in regeneration, you have replication of DNA. You can have mutations happening because it's a chronic thing. That regeneration doesn't stop once, it continues happening. And you know that if a cell continues to divide, there's a high chance that it's going to acquire DNA mutation and it's going to go towards the pathway of carcinogenesis. So that is why a background cirrhosis can lead to cancer. Yes, so that is it. Then for Helicobacter pylori can also cause chronic gastritis because Helicobacter pylori has so many mechanisms by which it can evade home immune response in the stomach. It will just stay there. It will release urease. You know, that urease will help it be neutralizing because urease will break down urea into CO2 and the ammonia. So the ammonia will be helping it. The CO2 will have escaped through the lungs. The ammonia is there neutralizing the gastric acid so that it can stay there. And it also has some factor that elaborate that protect it against, you know, neutrophilic invasion. So you have to, it infection persists for a long time, and you need to recruit the chronic inflammatory cells. So when the chronic inflammatory cells and the macrophages come around, it will cause chronic gastritis. Now, one thing I want us to always remember about this Helicobacter is that the chronic gastritis actually progress to cause intestinal metaplasia. And we have said it when we're talking about adaptation, that whenever there's a metaplasia, there's a high chance that that stuff can go to a dysplasia and go to cancer. So that is that about Helicobacter pylori. It can cause chronic gastritis that will proceed to form intestinal metaplasia that can now go to cause gastric adenocarcinoma. Those are the outcomes of chronic inflammation. Now let's talk about
Somebody, sorry, please. Please, I understand that macrophages, what's it called, are been produce interleukin 12 and activate naive T cells to purchase it to TFR1 cells. But how do we come about TFR2 cells?
So I said when those TFR1 are stimulated, you know, it is not only gamma interferon and TFR1. Sorry, there's something else. There's an echo there. So it is not only it is not only gamma interferon that those TFR1 secrete. They also secrete interleukin 2. Do you get it, Dr. Precious? If you go to immunology,
Okay, also interleukin 2.
interleukin 2 will activate the TFR2.
Okay, maybe I got that's why I didn't get. Okay.
Yeah, that's true. So wound healing occurs.
Mr. Babangwe, I have a question. Sorry.
Okay, Dr. Zulia.
My question is, we know that the Th1 cells secrete interferon gamma and activate the classical activation. Maybe it's that classical activation that I don't understand, because I know that when we were following the classical pathway, I know that immunoglobulin M and immunoglobulin G are involved. So I'm wondering, is this that same classical pathway or is it another one? Okay.
No, that is classical pathway of complement activation. This is classical pathway of macrophage activation. They are just using that name to qualify the activation of the macrophage. It doesn't necessarily mean that it produces IgM. Now, those ones are complement.
Okay.
Those are complementing. You see? So when you say
Dr. Babayade,
yeah, Dr. Olushola.
finish what you're saying.
So when you say a macrophage is activated in the classical pathway, it will be elaborating pro-inflammatory cytokines like interleukin 1, TNF, or the other ones. But when a macrophage is activated via the alternative pathway, it will release anti-inflammatory cytokines like transforming beta growth factor, which we said that in addition to having an anti-inflammatory effect, it also releases, because it can activate fibroblasts. We are going to see it downwards. It can activate fibroblasts that can cause fibrosis because they want to repair. So in the process, they are going to causing fibroblast deposition and fibrosis, which will lead to scarring. Do you get it, Dr. Zulian?
Yes, I do. Thank you.
Dr. Babayade, I just wanted to backtrack on these TFR1 cells. What stimulates the TFR1 cells before it stimulates interleukin 2 and interferon gamma? What stimulates TFR1 cells? Interleukin 12, right?
Interleukin 12 from the macrophage.
So what? Okay, from the macrophage. Interleukin 12 is from macrophages.
It's from the macrophages. The macrophages are the one that first capture the antigen.
Okay, capture antigen. Okay.
The antigen presenting cells. So they capture the antigen, they travel to the lymph node to present the antigen to the naive T cells that are there. So once they present it, they will now release interleukin 12 so that naive T cells will differentiate towards the TFR1. So the TFR1 will take it from there.
Then you now said the macrophage, after it has released interferon gamma, the TFR1 cell release interferon gamma to activate macrophages. Then it now causes reactive oxygen species. Then what again?
So it can release cytokines like TNF1, interleukin 1, and all those things. It can elaborate reactive oxygen species, lysoma exam. All those ones will cause inflammation and damage.
Okay.
Yeah. So
thank you.
Yeah, you're welcome, Dr. Bishop. So wound healing, let's just ignore what is on top first. Let us go to the phases of wound healing. Don't worry about all what is here. You know, we should just concentrate on the phases. 3 phases: inflammation or the inflammatory phase, the proliferative phase, and the remodeling phase. What happens in the inflammatory phase? if there's an injury causing a wound, there's going to be damage to a vessel. That's why there's, the injury. The vessels will be exposed. That's why they'll be bleeding. The first thing the vessel will do is to undergo vasospasm. After that vasospasm, they'll try to seal that opening so that bleeding will reduce. Then the next thing is the platelets will be aggregated so that they can form a temporary platelet plug to secure hemostasis. You form clot. Then the next thing that will help you finalize the clot formation is that the endothelial cells, they'll be exposed already. You activate the intrinsic pathway of coagulation. Sorry for some of us that have not done hematology. There's this intrinsic pathway that's activated when you damage the blood vessel that will now lead to activation of fibrinogen, and it will lead to fibrin. Let's just know it that way. So it will lead to activation of fibrinogen that will go to fibrin at the end of the day. All of them will now form the clot. So the platelet that is aggregating, the fibrinogen that is going to fibrin will now lead to formation of the clot so that you can seal that vessel and you can limit the bleeding. Then the next thing is that, of course, there's going to be already inoculation of microbes. The macrophages will have been attracted to come and pick on all those. The macrophages will have been attracted to come and pick the microbes. The mast cells will have been activated too because there's an inflammatory response immediately. So there's vasodilation. The vasodilation will lead to recruitment of the neutrophils and more macrophage. And we know that the next thing that will happen is what? Leukocytic extravasation to the site from the blood vessels. They want to enter that site of injury. So those are the things that happen in the inflammatory stage. You want to secure hemostasis, then the inflammation now starts properly. We start with vasodilation. After vasodilation, there's leukocyte extravasation into the tissue. So the cells that are typically involved include the platelet that forms the clot, the neutrophils and the macrophage that wants to respond to that tissue injury. If there's a necrotic tissue there, they want to respond to it. If there's a microbe there, they want to respond to it by inflammation. That is that. That is that. Then the next thing is there's a wound. We need to close that wound. That's where the proliferative phase now starts. How would they want to close that wound? So, vasodilation has happened initially. So, yeah, before I mention that, let me mention that 3 things typically occur in this proliferative. I think I have it here. Yes. So, we have the proliferative phase now. 3 things happen: fibroplasia, angiogenesis, and epithelialization. Fibroplasia, angiogenesis, and epithelialization. So you want to cover that wound. The way the body will start achieving the covering process is to undergo fibroplasia first. So fibroblasts are going to come around to that area and they'll start depositing granulation tissue. So they start depositing granulation tissue, and part of what attracts fibroblasts to that area is due to the fact that the macrophages that are there from inflammation release growth factors. We are going to talk about those growth factors later. So part of those growth factors include fibroblast growth factors, transforming growth factor beta, platelet-derived growth factors. All those things can activate the fibroblast. So when the fibroblasts are activated, they'll start depositing grant substance. They'll start depositing type 3 collagen. So in that wound, you are going to see grant substance that contains extracellular matrix like fibronectin, like glycosaminoglycan. Those are the things that will be present in the granulation tissue. Then they also deposit collagen type 3 on it. By the time you're having collagen type 3 on it, you're already having something that looks like a scar. Then the next thing is that granulation tissue has formed a matrix for blood vessel to form within that wound. Because you need blood vessels to form, because you have damaged the previous blood vessels. You need blood vessels to form inside that granulation tissue so that you can recruit more white blood cells and you can recruit more proteins to help with the healing. So the next process is angiogenesis. So you have ingrowth of capillaries within that granulation tissue so that you can have blood flow to facilitate the healing process. So after that, you now have that blood flow is now going to deliver more cells like the epithelial cell. So epithelial cell will be delivered, and epithelial cell, what we do is that it will now achieve a final covering over that wound. Epithelialization, it will form like a skin over it so that it can form a barrier between that wound and the external environment, and stuff like microbes cannot enter that wound. So we have said three things.
Sorry. The angiogenesis is it still within the proliferative stage?
Yes,
Yes.
yes, it's within the proliferative stage, because you are proliferating new blood vessels. That is angiogenesis. So the portion of granulation tissue, that is fibroplasia. Then the last one is epithelialization, recruitment of epithelial cells so that it can form a final covering of skin, separating it from the external environment. But what I want to say is that after you have, formed the granulation tissue, after the blood vessels have grown into the ground substance, you might want to contract that wound so that you can shrink the wound and kind of oppose the edges towards each other. Not completely, but it will move towards each other. What will do that? Your fibroblasts will now differentiate into myofibroblasts. Now, we call fibroblasts that have achieved contractile protein. So fibroblasts with contractile protein are known as myofibroblasts. Those ones will now contract. They will contract to move the edges of the wounds together to shrink that wound, to shrink the wound. And of course, the clots that are formed in the inflammatory phase from the platelets will be dissolved. So from there, we can figure out all the cells that will be involved in the proliferative phase. The first thing we said about the proliferative phase is that, okay, you want to lay down granulation tissue and type 3 collagen. That is involving the fibroblast. That's the first cell. The second cell is that you want to form new blood vessels into that ground substance so that you can take in protein, you can take in more white blood cells that can help you continue the other process, angiogenesis. And what can help you to form new blood vessels are the endothelial cells. Endothelial cells are the second cells. The third thing we said is epithelialization. We want to form new epithelial covering over that granulation tissue.
Dr. Baba, they need zinc here, right?
Eh?
Is this where zinc is important?
I will mention zinc. That will be the last phase. I'll mention zinc. So, Dr. Olusola, can you see the screen? It's like, I'm not sure you can see the screen.
No.
You can't see the screen, Abby?
No.
Why now? Look at the screen.
Maybe it's my network.
Okay, just try and log in and log out. So, zinc will be located in the last part. Zinc is in the last phase. So after you form the new blood vessel, the last thing is, okay, we want to form epithelial cells over that covering. What will help you form epithelial cells are the keratinocytes. Keratinocytes will help you achieve that. Then we also talked about shrinkage of that wound. You want to shrink that wound. You want to shrink it. That's when we have our fibroblasts now differentiating into myofibroblasts that can contract and shrink the wound to contract the wound and reduce its size. Then the macrophage will also help remove all the cellular debris that is remaining, like the clot and other white blood cells that are necrotic tissue that are contaminating those areas. Now, the element that we require here includes vitamin C and copper. Why? Because it is at this stage that we are depositing granulation tissue and type 3 collagen. And to form type 3 collagen, we need vitamin C. Type 3 collagen is coming from proline and lysine. So we need to hydroxylate those proline and lysine. Vitamin C is important. Copper is also important for the activity of lysyl oxidase that help us cross-link all those collagen fibrils. So you need both vitamin C and copper in the proliferative stage, which is a stage where we are forming our type 3 collagen. Then after the proliferative stage, the last phase is now remodeling. In the remodeling, what we are just doing is that we are converting that type 3, we are breaking it down, and we are converting it to type 1 collagen. We are remodeling that collagen that is there. And that involves some enzymes called collagenase. That enzyme requires zinc to function. So collagenase is what will remodel our type 3 collagen, break it into type 1, and we need to do that so that we can increase the tensile strength of the tissue, because type 1 collagen has more tensile strength than type 3 collagen. So somebody that has problem with conversion of type 1, type 3 to type 1, we easily have the breakdown of that wound because it doesn't get remodeled. The tensile strength is kind of reduced because there's no type 1 collagen. So anybody with zinc deficiency will have delayed wound healing because the wound will not eventually heal completely. So zinc is important for wound healing because it's important in the remodeling phase, which is involving conversion of type 3 to type 1 via the activity of the collagenase. What is releasing those collagenase are the fibroblasts. So we can remember the days. Inflammatory phase occurs between the onset of the stuff to 3 days. For proliferative, is the 3 to weeks. Remodeling is week to 6 months. It's not really very important, but if you want to remember, it's very easy to remember. So within 3 days, inflammation, 3 to 1 week, proliferative, then 1 week beyond. Within 6 months, you are expecting your wound to have healed properly, remodeling. Now, let's now go to look at all those mediators that are involved in all those things. So, fibrous growth factor is one. It stimulates angiogenesis predominantly. Now, this guy is more like a misnomer. Don't get confused with the fibrous growth. It can attract fibroblasts too, yes, but it's majorly important in causing recruitment of the endothelial cells so that we can have angiogenesis for the wound to heal. The next one is transforming growth factor beta and platelet-derived growth factor. I like to marry these ones together because they do the same function. Both of them will stimulate angiogenesis and they will stimulate fibrogenesis. Platelet-derived growth factor will activate the fibroblast for collagen. It will also, remodel the vascular tissue and allow smooth muscle to go inside the vessel so that it can be strong. That's what the platelet. So it's more like it does angiogenesis, just like transforming beta. Don't forget, the transforming growth factor beta and the platelet derived, they are both important for angiogenesis and fibrosis. The vascular endothelial growth factor, that one follows its name. It stimulates the proliferation of endothelial cells so that you can have angiogenesis. Then, in addition to all these growth factors, we also have the metalloproteinases. So an example of that is the collagenase here. So collagenase is an example of metalloproteinase that remodels the tissue by breaking down collagen type 3 to collagen type 1. So that's when you need your metalloproteinase. An example of that is collagenase. Then the last one is epithelial growth factor. That is the one that is present within the keratinocyte that allows proliferation of our epithelial cells for final epithelialization of the wound. So once you're able to remember all these phases, you'll be able to figure out what the mediators are doing. That's basically everything about
it.
Yes, Dr.
Sorry, I'm not sure if I heard what you said about TGF beta, but I'm just thinking about the fact that if we know that TGF is anti-inflammatory, but over here we can see that it's mediating fibrosis.
Yeah,
I don't know if I missed something.
No, fibrosis is not an inflammatory process. Fibrosis is a repair process.
Oh yeah, okay.
You remember when we were talking about
Right.
macrophage activation?
So
it's
yes.
it's part of repair. So
Right.
Yeah.
Okay, thanks.
So don't forget this. You can see this in your exam based on experience. This vitamin C and copper, they can come. They will ask you what phase is problematic. You already know what to pick. Zinc, you already know what to look out for. Zinc is a remodeling. That's the last one. Vitamin C and copper is a proliferative because both are the ones that will help us form collagen type 3. But for the remodeling, which is a late phase, you need to form collagen type 1. And to form that collagen type 1, you need to break down collagen type 3. And to break it down, you need collagenase, which is an example of a metalloproteinase. And that collagenase works only in the presence of zinc. Very important. So let's go to chronic inflammation. So chronic inflammation is a form of, I said chronic, granulomatous inflammation. So granulomatous inflammation is a form of chronic inflammation. So here, the inciting stimulus is just stimulating formation of granulomas, and it is typically mediated towards some particular infections, some um, some immune-mediated disease, and foreign body. So when you say a granuloma is just like a complex of immune cells that involves aggregation of the macrophages and the T cells surrounding that inciting stimulus. That is a granuloma. When we have the macrophages and the T cells now surrounding that stimulus, confining it, walling it off, we have a granuloma. And that only happens when it is very difficult to eradicate or degrade that stimulus. So what are the stimulus? Tuberculosis, infections like tuberculosis, there's a lot of them. Infection like syphilis, leprosy, there are so many. If it's not an infection, it can be due to foreign body, like someone that have taken in silica, inhaled silica, someone that inhaled beryllium, someone that has inhaled coal dust from all these miners, so many things. And it can also be due to some immune-mediated disease. We are going to talk about that. So once you see granuloma, you know that there's likely to be walling off of that stimulus by the T cells and the macrophages. And we've said it that the cells that are involved in chronic inflammation are the T cells, the macrophages. So at the end of the day, those macrophages that are surrounding that granuloma will be activated by both classical and alternative pathway. So classical, we want to be releasing pro-inflammatory cytokine to destroy that organism, to destroy the foreign body, which will not work. At the end of the day, you still have simultaneous activation of the macrophage through the alternate pathway to start to repair by fibrosis. And that is why one of the complications of granulomatous disease is fibrosis and organ damage at the end of the day. So this is how the histology will look like. So you can see a central, this one is even showing a central necrosis here. So a granuloma can have central necrosis or might not have central necrosis. So if it has a central necrosis, that is a caseating, granuloma. If it doesn't have central necrosis, that's a non-caseating. So the non-caseating is very common for non-infectious causes because there's nothing for you to break down. But for the caseating, it's majorly due to infectious causes. So let's look at how it looks like. You can see the central necrosis. You can see the surrounding layer. This is likely to be the macrophage. Then the one at the outermost portion are the T lymphocytes. So let's look at the complex. So we have a focus of epithelial cells. So epithelial cells are activated macrophages. So once those macrophages are activated, they will become enlarged and they will assume the shape of epithelial cells. So that's why we call them epithelial cells. They'll be surrounded by the T lymphocyte, particularly the CD4 cells, not even the CD8 cells. It is the CD4 cells that is there next, alongside with multinuclear giant cells. So those are fused activated macrophages. So once those macrophages have become activated and they have formed epithelial cells, they will surround the antigen. Then the next thing is those activated macrophages start fusing together to form giant cells. So those giant cells and the T cells will be at the outermost portion of the granuloma. So from inward to outward, in the central portion, you have the antigen. But it is not in all situations that you have an antigen or you know the antigen. You can have the antigen, but we don't know the antigen in most situations. For the case of tuberculosis and fungal infection, we know that what is inside is the fungal antigen or the tuberculous organism. But in some immune-mediated disease that cause granuloma, like Crohn's disease, sarcoidosis, we don't know the inciting antigen. We don't know. So whatever the antigen is, the next thing that will surround the antigen will be the activated macrophages. The activated macrophages. Then the next thing that will now surround those activated macrophages will be the fused macrophages, which are the multinuclear giant cells, alongside with the CD4 cells, the TFR T cells. Now, let us talk about what can incite them. Let me just mention it again. So for the infection like tuberculosis, fungal infection, they can cause granulomatous disease. Immune-mediated disease like Crohn's disease, like sarcoidosis, like Which one is there again? Primary biliary cirrhosis, granulomatous polyangiitis. There's a lot of them. There are so many. Then foreign body too, like beryllium, berylliosis, silicosis. All those things are very difficult to degrade, so they tend to allow for formation of granulomas. So what is the mechanism of granuloma formation? Let's take.
Dr. Bala,
Yes, Dr. Fresh.
sorry, before you continue. So I'm having issues separating granulomas from abscesses in terms of talking about word of what's it called?
Okay.
Infection. So like abscess, we drain that one too, and they usually say until you move the wall, like they also have a wall. I don't know how to put it.
Yes, they have a wall, but their wall is not formed from T cell and macrophages. What is forming the wall for abscess is proliferating blood vessels and fibroblasts. It's fibroblasts that is surrounding that area, as well as the proliferating blood vessels. So there's an area of fibrosis and proliferating blood capillary vessels. Those are the things that is worrying us. But for a granuloma, it is the macrophages and the T cells. Do you get it?
So yeah, I guess so. That means that like the way it's looking like granuloma is like more of like an histology diagnosis. Like you have to look at the microscope.
Yes, it's an histology
now.
diagnosis.
I think I get it now.
Histological. That is what you are seeing.
I thought you should see it. Okay.
That's why you are seeing this image A. It's an histology diagnosis. You are very correct. So, let's take tuberculosis for an example, now. And the tuberculosis antigen is picked up by the antigen presenting cells. They will present it immediately to the CD4 cells, so that the naive CD4 cells can release interleukin 12. Just like what we have said earlier, interleukin cells will now become the TFR1 cells. TFR1 cells will now activate.
Sorry, Dr. Bawale, is it interleukin 12 and that? Because you were saying interleukin 2 before when we were talking about chronic inflammation.
No,
for the starting.
For the starting. The antigen presenting cells go to the lymph node and release interleukin 12. In the lymph node, what we have there are the naive T cells. They have not committed to any of those pathways. So by the time we release interleukin 12 for the macrophages, they will be forced to go to TFR1. Do you get it, Dr. Murray?
Okay.
So when the TFR1 is not activated, TFR1 will now release gamma interferon. So gamma interferon will now further activate those macrophages. So once they become activated, they will now differentiate into these epithelial cells. They will become enlarged. They form the epithelial cells. So it is this activated, of course, this macrophage that's activated in response to this gamma interferon is going to start releasing inflammatory cytokines. So this is more like a classical activation. Can you remember that, Dr. Brava? Just like what we have said.
What I'm asking is, where does interleukin 2 come in?
So interleukin 2 is when you are now talking about the alternate pathway of macrophage activation. Because interleukin 2 will activate TFR2. So when TFR2 is activated, it will now start activating this macrophage too, but in the alternate activation. And the macrophage that is activated in the alternate pathway is anti-inflammatory.
Okay. Because interleukin 2 comes in much later, it's not in the...
Yeah, they actually go hand in hand. As one is happening, the other one is happening too. As one is happening, the other one is happening. Yes, so they go hand in hand.
Okay.
So but the formation of this granuloma now, this is how it starts. So just like we said, once for a TB infection comes in, the what's it called? The macrophages will pick the antigen, they will go to the lymph node, they will stimulate the naive T cells in the lymph node by releasing interleukin 12. So the naive T cell will be forced to go to to go to TFR1. So once TFR1 is activated, TFR1 will release two things, interleukin 2 and gamma interferon. If gamma interferon is the one that is kicking in, the gamma interferon will now start activating the macrophages. When they get activated, they will now form this epithelial cell. They become enlarged. And they start elaborating some pro-inflammatory cytokines too, because classic activation makes the macrophages elaborate pro-inflammatory cytokines. One of them is TNF. One of them is TNF. Now, this TNF is now going to act again on the macrophage that is releasing them. It will now make those epithelial macrophage fuse together to form giant cells. So it is the giant cell that will now go and be surrounding the epithelial macrophages. Then the T cells too will be surrounding them at the outermost portion. I don't know if I've confused you guys. Have I confused you guys? I know that the pathway is kind of stepwise, but do we get it?
It's fine. Yeah, yes.
So we should just know that.
Dr. Babawale, please, I don't really get it. Can you elaborate?
Okay.
Babawale,
So
please, can you again the mechanism of the granulomatous inflammation? Thank you.
So is that Dr. Antonia? Dr. Antonia is here. Okay, Dr. Antonia. Okay. So
It's not me, oh, it's not me.
okay. Dr. Antonia. Okay. So hello. Yeah, so what we are saying is once the tuberculosis comes in, macrophages will respond to it because they're antigen presenting cells. They will capture some portion of the tuberculosis and they will go to the lymph node. Once they get to the lymph node, they will release interleukin 12. That's the first thing they do. They release interleukin 12. Interleukin 12 is going to act on the naive T cells in that lymph node and it will make them go to THEPA1. So once THEPA1 are formed, THEPA1 will release gamma interferon. Once THEPA1 release gamma interferon, the purpose of gamma interferon is to activate the macrophages again. They will now activate the macrophage. We have said it initially that whenever a macrophage is activated by gamma interferon, that is classical activation, and that macrophage will be elaborating pro-inflammatory cytokines. Now, the cytokine that is going to elaborate now is TNF, tumor necrotic factor. This tumor necrotic factor is now going to make the macrophages form epithelial cells. They are going to get enlarged. And those epithelial macrophages will also fuse together to form giant cells. So those ones are due to response of the macrophage to the TNF that the macrophage are secreting by themselves. When the macrophage become activated, they release TNF. That TNF is going to have an autocrine effect on the macrophage. It will now going to stimulate that same macrophage to become epithelial cells. They become enlarged and they will fuse together to form giant cells. So that means that in a way, they are completing the cells that are required to form that granuloma. We have said it. The first thing that you need to form is the epithelial cell that's surrounding the antigen. Then after the epithelial macrophages, the next thing are the giant cells, which are the fused epithelial macrophages. Then the T cells, which are the CD4 cells, those ones will be at the outermost portion. Do you understand it now?
Yes, thank you.
All right. So the clinical significance of this one is that you don't want to give anti-tumor necrotic factor therapy, because if you give anti-tumor necrotic factor therapy, you cannot form the epithelial macrophages and you cannot form the giant cells, which are essential components of the granuloma. So there's a possibility that the granuloma will break down. So if you want to give somebody anti-tumor necrotic factor in someone that you are in an individual, you must always rule out tuberculosis. Because if this person is having tuberculosis that is kept latent by the granuloma, once that granuloma breaks down, the tuberculosis will reactivate. It will reactivate. Because the granuloma breaks down, the tuberculosis will find its way outwards. So that is why before you give anybody anti-tumor necrotic factor, you want to rule out tuberculosis. This is a very, very important stuff. Then, before we leave granuloma, there's something else about the activated macrophages. Once they become activated, there's increased activity of alpha-1 hydroxylase in these macrophages. Alpha-1 hydroxylase will now activate 2,25 hydroxycholecalciferol it will hydroxylate at the first carbon, causing formation of 1,2,5 dihydroxycholine calciferol. We've said it. The substrate that this 1-alpha hydroxy is acting on is 25 hydroxycholine calciferol. So it will activate it, it will hydroxylate it at the first carbon, causing formation of 1,2,5 dihydroxycholine calciferol, which is vitamin D. And that will cause reabsorption of calcium, just like we mentioned when we were talking about metastatic calcification. It will start reabsorbing calcium from the intestine, reabsorbing from the bone, and there's hypercalcemia. That is why hypercalcemia is one of the predominant feature of sarcoidosis. Sarcoidosis can form granuloma. The activated macrophages in sarcoidosis can have this increased 1-alpha hydroxylase activity. They will produce vitamin D, which will lead to hypercalcemia. So we can see this picture of everything just to revise. The macrophages present the antigen to the T cell. They will stimulate the release of interleukin 12. The T cell will get converted to TFR1. This TFR1 will elaborate gamma interferon. Gamma interferon will activate the macrophages. The activated macrophages will release TNF. The TNF will now act on these activated macrophages, converting them to epithelial cells and giant cells. So all the cells that you need to form the granuloma is complete. You have had your TFR1 cell formed already. You have had your epithelial cell formed already. You have had your giant cell formed already. All of them will now surround the antigen and they form a granuloma. That is it. So what are the etiologies? Infectious, non-infectious. Infectious, non-infectious. You might not need to learn all these things now because it might be difficult. You might forget. But as we are going through all the systems, we'll be learning them one by one. You understand them as we are going. But let's just run through it. So for the infectious one, we can classify into the bacterial, fungi, and parasitic. So the only parasitic one is schistosomiasis. That's the only one that can form granuloma. Yeah, that occurs that we know here. So for the bacterial, you must always remember the mycobacteria first. So tuberculosis and leprosy can form granuloma. The Mycobacterium leprae, Mycobacterium tuberculosis, they can form granuloma. Then there's a bacteria that we call Bartonella encephalitis, which is important in forming because it's catch-crowd disease. So that catch-crowd disease can be a shell formation of necrotizing granuloma that looks like star. That's why they call it stellate. So star-looking granulomas, that is Bartonella encephalitis, catch-crowd disease. Listeria can also cause granulomatosis infartiseptica. It's a form of granuloma that you see in the body of the newborn. So they form this nodular rash. It might not make sense to us now because we have not done microbiology, but you know, it will make sense to us as we are moving through this. We might not be able to remember all those things now. So in addition to tuberculosis, tertiary syphilis can also cause granuloma. And form granuloma against this syphilis organism at the tertiary stage. Systemic mycosis generally form granuloma. Histoplasmosis is one of them. Blastomycosis is another one. There's a lot of them. All the systemic fungi, they typically form granuloma. Then parasite that we've talked about, schistosomiasis. Then all the catalase positive organisms can cause chronic granulomatous disease. We've talked about this in immunology. So all those E. coli, those Burkidophila, Serpatia, you know, those Staphylococcus, Apophyticus, Nocardia, Aspergillus. Those are the ones that they commonly ask. Aspergillus, Nocardia. You must remember those ones as causes of chronic granulomatous disease because of the catalase positivity. Then the non-infectious one. So this one is not due to infection. So all these infectious ones, you most likely see a caseating necrosis. So that center at the middle is going to be necrotic because they will destroy some of the organisms, the other ones will persist. But for non-infectious, you are not likely to see central caseous necrosis because in most of these things, is either the antigen is non-degradable or we don't even know the antigen. So these non-infectious, they are categorized into three forms: immune-mediated, the vasculitis, and the foreign body. So let's start with the foreign body. The antigen that is driving the granuloma are the foreign bodies like beryllium, like tacosys. So tac is actually a component of drugs. So people that take urine and cocaine. So tac is one adulterated substance that they add to all those cocaine so that you can increase the quantity, you can increase the volume so that it will be more. You can adulterate it. So once the person inhales it, it's non-degradable. It can lead to formation of granuloma, just like beryllium, just like silicon. Then there's something called hypersensitivity pneumonitis, which is due to inhalation of bed droplings. So we also call this guy. So anybody, old guys, what is another name for hypersensitivity pneumonitis? Please tell us.
Pneumoconiosis.
Yes, pneumoconiosis. But which one particularly? What other name? Hypersensitivity pneumonitis. Doctor.
Psittacosis or something.
Is it farmer's lung?
The farmer's lung, the one that they have birds,
Yeah.
that they rear birds.
Farmer's lung, bird fancier disease.
Bird fancier, yeah.
Psittacosis is a form of pneumonia from Chlamydophila psittaci. So, yeah, so they can form, that one is not typical affair of granuloma. Psittacosis. That one psittaci is a chlamydial infection. So, hypersensitivity pneumonitis can form granuloma in response to bed droplings. That's why I call it bed fancier or farmer's lung, because farmers are the ones that rear beds. So you should not forget that. Vasculitis too. There's some vasculitis that fear formation of granuloma, like the Wegener's. So I might not want to talk more about this until we get to musculoskeletal. We understand it very well there. So there's some vasculitis that can form granuloma, like the granulomatosis with polyangiitis, eosinophilic granulomatosis with polyangiitis, then temporal arthritis. Don't worry about that. When we get to that part, we are going to talk more about it. So then the immune mediated ones. These ones particularly, you don't know the origin. It's just there. Sarcoidosis, Crohn's disease. They typically form granuloma, but we don't know the particular inciting antigen. Some say environmental, some say genetic, and all those things. So many postulations. So sarcoidosis and Crohn's disease are immune mediated form of granulomatous disease. Some vasculitis have granulomatous lesion in them, like the Wegener's granulomatosis, the Churg-Strauss. So Wegener's is granulomatosis with polyangiitis. Churg-Strauss is eosinophilic granulomatosis with polyangiitis. Then you can have granuloma formation in the blood vessels of the head in case of Takayasu and temporal arthritis. So yeah, so that is that about. So let's just end with scar formation. So we'll start from neoplasia. So very, very straightforward. Scar formation just happens in a tissue that cell regeneration alone cannot initiate the repair. If, for example, it's very unlikely.
Dr. Wale.
Yeah, Dr. Precious.
Dr. Adefunke is raising her hand. She has been trying to talk since.
Oh, I'm sorry.
I didn't want to break it.
I'm not looking at the screen. I'm not looking at our name. I'm sorry. Yes, ma'am.
No problem. Please, I just I'm a little lost on the activity of vitamin D where you were mentioning hypercalcemia. I don't know if you can quickly go over.
So it's because we have not done what are we going to talk about is kidney. Is it kidney now? So what vitamin D does is to reabsorb calcium from the kidney, reabsorb calcium from the intestine. It can also reabsorb calcium from the bone. So vitamin D is important in forming strong bones because it can elevate the calcium level, and the calcium can mineralize the bone. So anytime there's increased vitamin D in the body, calcium will be reabsorbed from the intestine, it will be reabsorbed from the kidneys and from the bone too. So there's hypercalcemia. Do you get that, ma?
I'm with you.
So vitamin D causes reabsorption of calcium from the intestine and the kidneys. So anybody that has a granuloma Because one of the components of granuloma is activated macrophages that we have talked about, those epithelial macrophages. So it has been shown that those epithelial macrophages have increased activity of 1-alpha hydroxylase. 1-alpha hydroxylase is an enzyme that acts on 25-hydroxyl cholecalciferol. 25-hydroxyl cholecalciferol. Once it gets acted upon by this 1-alpha hydroxylase, it's going to convert that 25-hydroxyl cholecalciferol to 1,25. That's already 2-hydroxyl dihydroxyl cholecalciferol, which is the another name for vitamin D. That is vitamin D. So 1,25 dihydroxyl cholecalciferol is vitamin D. So it means that if somebody has a granuloma, and of course in the granuloma we have activated macrophages, so they have increased 1-alpha hydroxylase activity, and they can easily convert 25-hydroxyl cholecalciferol to 1,25 dihydroxyl cholecalciferol, which is also known as vitamin D. So that vitamin D will now start causing reabsorption of calcium from the intestine and the kidneys and the bone, elevating the level of calcium in the blood. So that's one thing you want to watch out for in some granulomas, particularly in sarcoidosis. There's hypercalcemia in them because of this process. So that is that. Is it clear now, Ma?
Yes, it is.
Okay.
Thank you.
So scar formation. So scar formation typically occurs in cells that are not capable of repairing that injury by regenerating alone. So it typically occurs when that injury is very extensive, that even if the cells are capable of regenerating, it's too big for them to handle. They might want to form little scar. Or injury is happening in a tissue that cannot even regenerate. Just imagine there's injury to a myocardium. People of God, if there's damage to the myocardium will not regenerate by epithelialization or regeneration. Myocardium contains permanent cells. They are muscles, just like neurons. They don't proliferate. They will have scar. So that is why somebody that has a myocardial infarction can have arrhythmia. Why? Because when there is myocardial infarction and there's ischemic injury to the muscles cannot repair that injury by proliferating. They want to repair it by forming scar. So if the electrical impulses are now passing through the heart muscle and they not get to that heart, they not get to that scar, they will stop. So they will stop. And that can lead to different form of arrhythmias, abnormal conduction of electrical impulses. So the point there is that whenever injury has happened in the tissue that is not capable of active proliferation or regeneration, the mechanism of repair will be scar formation. And scar formation is where you deposit connective tissue, ground substance, collagen in a tissue, particularly collagen. That's what we must always remember. And we said it that collagen type 3 is the one that first gets deposited. Then our collagenase will come in, cleave it. Collagenase is the one that is dependent on which nutrient, which mineral is important for collagenase to work.
Zinc.
Zinc. So once you cleave it to collagen type 1, you have increased the tensile strength. So just like we said here, non-regenerated cells secondary to severe acute or chronic injury are replaced by connective tissue, which is a scar, non-regenerated cells. 70 to 80% of the tensile strength will be regained after 3 months. So after 3 months, you have abundance of collagen type 1. Then afterwards, little tensile strength will be gained. So what is responsible for formation of scar is TGF-beta. This point must be emphasized. TGF-beta is notorious for causing fibrosis. It is notorious for causing scar. Very important. That's the first thing that you must pick. Please, you will see fibrous growth factor in the option. Don't pick fibrous growth factor. Fibrous growth factor is responsible more for causing angiogenesis. The one that recruits the fibroblasts more is the TGF beta. And when there's overactivity of this TGF beta, you tend to have abnormal scarring. Instead of you to have a fine scar, if the activity is too much, you tend to have an hypertrophic or a keloidal scar. So let us differentiate between hypertrophic and keloidal scar. It's very easy.
So, Baba, please, before you move on, I wanted to like solidify the knowledge about the collagenase something, because we were talking initially, we said collagenase helps us in remodeling, and that eventually helps us, like the remodeling causes there to be increased tensile strength in the scar that we formed, right?
Yes.
But here now in the scar formation, there is defective collagenase, and they're like saying 70 to 80% of tensile strength we get at 3 months. I really don't understand that statement.
No, defective. There's no defective collagenase now. Where do you see that?
Well, no, I'm not really saying defective collagenase, because I'm just trying to. Okay, is the collagenase function? Is it working? Is it properly?
No, what is causing this? Okay, now let me go back. What they are saying here is that they said scar formation. What will lead to scar formation? Normally, an injury should repair itself by regenerating the cell and not form scar. But there are some tissue that they cannot regenerate. Like that's why I gave the example of a muscle. Because they don't contain actively proliferating cells. So they will
permanent cells.
Exactly. They will repair themselves by forming scar. So they said non-regenerated cells, when they are exposed to severe acute or chronic injury, they are replaced by connective tissue. Scar. They now said 70 to 80% of the tensile strength of that scar, of that injury, of that wound is regained at 3 months. So I'm now saying it means that you have at that 3 months you have abundance of your type 1 collagen, because type 1 collagen is the one that is increasing the tensile strength of the scar. Do you get it, Dr. Zubia? Because we said it that the remodeling phase occurs between 1 week to 6 months.
6 months.
So by 3 months, you will have had dominance of type 1 collagen that will be increasing tensile strength. So they said after 3 months, little tensile strength will be. So it means that majority of your type 1 will have been formed by 3 months.
3 months, okay.
Now, and you know that what is driving that deposition of collagen is what? Activation of fibroblasts by TGF
beta.
If there's any stimulus that is now causing overexpression of this TGF beta, probably if that wound is too extensive, you can have overexpression of this TGF beta that will not lead to aberrant scarring. That is, you have too much scarring. And we have two forms of too much scarring, hypertrophic and keloidal scar. So that is what we now want to start looking at now. So let us look at the type of collagen that both of them contain. So hypertrophic scar is more like an immature scar. It contains type 3 collagen only. It's immature. Keloidal scar has both of them, both the immature form and the matured one. Type 1 and type 3 are present in the keloidal scar. Why hypertrophic is immature, type 3. You can see that hypertrophic scar looks very clean. It is actually due to the fact that the collagen that are deposited there are deposited in parallel, well organized form, in parallel orientation. But that of the keloidal scar, they are scattered. Parallel, series, different configuration that is not well established. It will make it look disorganized like this person here. The collagen are disorganized. They don't have any particular orientation of deposition. Then, very important point to know, what is the extent of the scar? You see, in hypertrophic scar, the scar doesn't go beyond the borders of the injury. They will be confined to the border of the injury. In keloidal scar, they actually outgrows the border. You can see that this one is even moving up. The insult doesn't even go in this shape. The insult may be maybe just one small incision like that, but they will outgrow that incision and grow in a scattered manner. You can see that it's even looking like a claw-like projection. They overgrow and they move beyond the border. They move beyond the border of the original wound. And keloidal scar have predilection for affecting some particular areas of the body. those areas of that we are talking about actually in the upper part of the body, like the upper extremities, the arm, or the chest, the upper part of the chest, the face, and the hair lobes. Those are the parts. So the upper chest, the face, the hair lobe, and the upper extremities. That's where keloidal scar is present. What is the chance of recurrence? Hypertrophic scar doesn't typically recur. So if you excise this guy, there's very low chance that it's going to recur. But keloidal scar, they recur frequently. Once you remove it, you excise it, or you put intralesional triamcinolone, a steroid there to shrink it, it will regrow, because majority of keloidal scar are genetic. What is driving it is usually genetic. It will come back. It will come back. So what's the predisposition? None, no predisposition. It just follows a normal injury. In keloidal scar, it is genetic, and it commonly occurs in people that are dark skin. I don't think I've seen any white person that has keloidal scar before. I don't think I've seen it. So most people that have keloidal scar are dark skin. So everything is actually due to excess activity of our transforming growth factor beta. That is what is driving that collagen deposition in an excessive manner. So they differ in terms of the collagen that is present. One is immature, one is both mix of mature and immature. The orientation of the collagen, one is parallel, the other one is disorganized. The extent of the scar, from what we are looking at, the scar of hypertrophy is just confined to the border, while those of the keloid is outwards, goes outside the border. The recurrent rate for keloidal scar is high because of father is genetic, while hypertrophic is not high. So there's nothing that predisposed to hypertrophic scar. But keloidal scar is common in dark people and is a genetic condition. So by God's grace, we'll be stopping here and we'll be starting malignancy. I thought I put some questions here. I'm so sorry. Let me check for. Okay, so let us look at this before we go. This thing is not coming up, sha. What's going on? Okay, so a 32-year-old chef accidentally slices into the tip of her thumb while hurriedly trimming something stick with a knife. The laceration extends through the skin into the subcutaneous pulp. Which of the following consequences is most likely to occur in the subsequent wound healing process? So do you understand what they are talking about here? Wound healing process.
Wound healing phases, no.
Yeah. So what do we think? So we have three things to choose. Sorry, I could not enlarge this thing. Cellular infiltration, fibrin cord formation, and angiogenesis. So which one do we think will happen first? Okay, I'm listening.
I think
fibrin clot formation
occur first.
Then cellular infiltration, then angiogenesis.
Exactly. So the fibrin clot is the first phase. That's the first phase of the inflammatory response. Then the next one is now vasodilation, so that the cells can come in. Then we now move to the proliferative phase. And what is happening in the proliferative phase is angiogenesis. So that's why the answer is E. No, it's not U. It is a fibrin clot. So that's how we have. Okay. Do I have another one here? I'm not sure I have another one. Okay. Oh, there's one here. I think this is the last one. This is the last one. Call it a day. A 24-year-old man is evaluated for recurrent episode of abdominal pain and bloody diarrhea. The man has also had low-grade fever and fatigue. Physical examination revealed left lower quadrant tenderness, CT scan of the abdomen shows thickening of the distal column and rectum. During one of the laboratory tests, the patient's anticoagulated blood is placed in an upright thin glass tube and left undisturbed. His red blood cells form a stack and settle to the bottom at a fast rate of 50 mm per hour. Serum level of which of the following substance is mostly associated with this observed finding? What are they talking about here? Spot diagnosis.
Yes, sir.
They are talking
Yes.
about ESR.
Yes.
Talking
Yes.
about ESR. So what is the factor? Even without seeing the option, what is the factor that we are looking for?
Interleukin 6.
Interleukin 6, chemotaxis.
Fibrinogen.
Okay, so you guys are actually correct. The thing is, you guys got the answer, but that was not the answer that I was expecting you guys to give me.
Fibrinogen.
Fibrinogen.
But we might not see fibrinogen in the option. We might not see fibrinogen in the option. So interleukin C will be correct because what the fibrinogen is an acute phase reactant, and what is affecting those red blood cells that is neutralizing those charges are the acute phase reactant, particularly fibrinogen. So if we not see fibrinogen there, we should look out for other acute phase reactants or anything that can upregulate the acute phase reactant. And here it is interleukin 6 that can do that function. I don't know if you guys understand what I'm trying to say.
Dr. Babawale, I still don't get it though. Because
Yes,
I feel
ma'am.
like this question is clearly asking about chemokines. What do we call them?
No, not chemical.
So, Abi?
See, look at it, Dr. Toby. Look at it. His red blood cells form a stack and settle
That
to the bottom.
is causing a fast ESR.
That is causing a fast ESR. High ESR. Why is it sedimenting fast? And we said one of the causes of high ESR
inflammation.
Okay.
Exactly. Fibrinogen. Fibrinogen is one of the acute. Let's go to the statement again before we go. So they said product of inflammation, e.g. fibrinogen. They can coat the red blood cell, they can neutralize the negative charge, and they will increase attraction between those red blood cells, making them dense, and they will fall at a higher rate, increasing the ESR. So it means that we are looking for acute phase reactant like fibrinogen. So if you are not seeing fibrinogen there, look for something that can increase fibrinogen, which is
or if the option was showing CRP or any other acute phase reactant, it would also be correct.
Yeah. That's a tricky one.
Do you get my question?
I get, but the thing is, we tend to marry CRP with ESR. You get? That's why I'm skeptical about saying CRP. Do you know why? We do the test individually. You measure CRP, you measure ESR.
Yeah.
So if ESR is high and CRP is low, you will even say that there's inflammation because we believe more in CRP than ESR. You get? So I want to believe that the major thing that is actually neutralizing the charge is fibrinogen. So not even, the other acute is fibrinogen predominantly.
I get it now. So fibrinogen, ESR, they like go hand in hand.
Exactly.
Yeah. Okay.
You get it. That's why you see, look at this statement. Correlate with ESR. You can see.
Yes, I just saw that statement. That's why I figured it out. Thanks.
It is so.
But the trigger, but the cytokine that triggers it is the interleukin 6.
Because interleukin 6 can upregulate acute phase reactants.
Late acute phase reactants.
And one of them is fibrinogen. All right. So do we have any question before we call it a day? Any question? Okay. So that means that we can start tackling questions under inflammation by now. I don't know why you all decided to go and put 3 questions in inflammation for us. It's a very sad thing. Actually,
no, there are ways that you set it that to bring more than 3 questions.
Under principles, are you sure?
Okay, other principles.
These principles. The thing is, the catch there is that once you try to engage more systems, the question will become complex. That is the stuff. It will become. It can
There will be
incorporate.
application questions.
It will now start becoming. God bless you, Dr. Zubia. It will now start becoming application questions, which you might not be able to answer for now. So that is my people.